Our government has been pushing more patient responsibility, larger co-payments, larger deductibles through a payer community that has facilitated that into the system from 2% patient responsibility 20, 30, 40 years ago to 4% to 6% to now 15%. By the way, not so much in hospitals. What happens when they are responsible and they're not in a position to pay?
Over the last 15, 20 years. You are right that we have sort of moved as a country to shifting greater and greater responsibility onto patients. That experiment has been a complete failure.
So looking back the last 15 years, what do you like about it and what do you dislike?
The law was deliberately focused on expanding health access to health insurance. And that had been a generations long dream by people who worked in healthcare in America.
How did you get into this line of work?
A very interesting and exciting time in American healthcare. President Barack Obama was talking about doing some big things, and I had covered a big congressional story to the crafting of the Affordable Care Act, but it was really, why.
I would say that's still 20 years later, the biggest story that we've seen in healthcare. That ACA policy set of regulations, the most transformational. Okay, I'm joined today by Noam Levey of KFF and previously the LA Times, who has been covering healthcare for how many years now, Noam?
Too many. Like 15 years, 17 years, yeah.
As long as I've been in healthcare, let's put it that way. And let me start, as I often start with, how did you get into this line of work?
Well, I mean, I should say I'm uniquely unqualified to do what I do.
We share that as well.
I'm a Middle Eastern history major, and I was an investigative reporter and a political reporter, and I had been working in the Washington bureau of the LA Times covering the 2008 presidential campaign. And when I got off the campaign trail, they needed somebody to cover healthcare, and they pointed at me, and off to the races.
You didn't even raise your hand. They just pointed at you.
No, I ran for the exits, but they caught me. But truth be told, I had never really thought about covering healthcare. My father was a physician, but maybe that's part of the reason why I thought I'd never do it. But I had gotten a little tired of covering politics because even back then, there was not a lot of fun in it, and it was very polarizing, and it seemed like everybody was having the same fights over and over again. And that, you may recall, that was a very interesting and exciting time in American healthcare because the new president, Barack Obama, was talking about doing some big things, and I had covered, when I first came to Washington, Congress, and it was obviously a big congressional story to cover the crafting of the Affordable Care Act, but it was really, fly when we were up in the air because I really did not have any background in any of the minutia of health insurance, much less some of the delivery system stuff that was being talked about back then, and which I'm sure you know far more about than I do.
But you really jumped in at the deep end. I would say that's still 20 years later, the biggest story that we've seen in healthcare. That ACA policy set of regulations, the most transformational. We've seen other changes. We've seen meaningful use. We've seen transparency. We've seen drug pricing negotiated by Medicare. We've seen stuff, but in terms of the breadth and scope of transformational change, I think you really started right at the top of transformational change.
I think that's right. And it was funny. I still remember at that time because I felt sorry for a lot of my colleagues who've been covering healthcare for decades because it seemed like it must have been so frustrating. The story was sort of stuck, right? I mean, advocates and Democrats in particular had sort of had this dream of expanding health insurance coverage and doing something big, and it sort of always ended in frustration and tragedy. And here was this big moment, and it sort of seemed like, wow, the world is really changing, which of course, as a reporter, is the most exciting thing to bear witness to. So yeah, so I think it was.
I think they had pandemic preparedness as new policy, like in 2004, but that was about the extent of it.
That's right. Yeah. I think it was incredibly transformational. With the passage of time and the accruing frustrations that everybody's living with now, I think there's a tendency to sort of think, God, all that drama and look where we are. But it is, I think, worth stepping back sometimes and thinking about what a big moment that was. For sure.
That's what I'm here for. So let me give ACA the Siskel and Ebert test, thumbs up, thumbs down. by Noam. So looking back the last 15 years, what do you like about it and what do you dislike?
So, the law was very deliberately focused on expanding health access to health insurance. And that, as I said, had been a generations long dream by people who worked in healthcare in America that, why was America the only wealthy nation in the country that didn't guarantee health coverage to its citizens? And, I can tell from your accent that you come from somewhere where that's sort of been a valued service.
I've been hearing the criticism since I was 10, going to high school in London. Those damn Americans, they don't care about their people.
That's right. And I'm not sure that's changed necessarily, but we do guarantee more health insurance. And I think, it was the American healthcare system, as I'm sure you've explored on your program, is this Rube Goldberg machine, right? Which doesn't really make sense to anybody. And the Affordable Care Act was sort of grafted on in a very awkward way to sort of meet the political necessities of the moment. But at a big scale, it did something really historic. I mean, there are a few states in this country where health insurance is still not guaranteed, but most of the country now guarantees health insurance in one form or another. And that's historic. And I think it can't be understated. And whenever I talk with people who wring their hands about the terrible state of healthcare in America today, I try to remind people, let's keep in mind that something really big happened. And, I travel the country. I've interviewed at this point probably thousands of patients from, Hawaii to Maine, and it's literally saved people's lives. So I think that's, if we said nothing else, if I were a movie reviewer, I'd have to give it 4 stars or whatever. By other measures, of course, I think it's fair to say it's been disappointing. It was billed as something that would control the cost of healthcare in America, and I don't think it's done that. Certainly not as much as had been billed, and it hasn't arrested some of the more troubling and I think destructive things that have been happening in American healthcare: the consolidation, the influence of money, the influence of Wall Street.
Not all money is bad. Bad money.
Bad money.
Bad money.
Bad money. But I think it's given power to forces that are not always aligned with, I think, what's in the best interest of patients. Let's put it that way.
Looking back, is that a surprise? I mean, when you think about, and so far I'm agreeing with everything that you're saying. I think a downward from 20% uninsured to 8 is monumental. When you think about how many millions of people that represents, right? 10% of the populace is 30 million people. That's nothing to sneeze at. But when you think about controlling costs through coordinated care and different reimbursement programs, that was always going to be hard and always going to take time. Not something that an academic can fix in one document, but something that needs to be through machinations, calibrated and recalibrated and corrected, like risk profiling scores for patients. Hard to get that right the first time. Fair?
For sure. Yeah. And not something maybe that government could do, honestly, by itself. I saw that you had Liz Fowler on here before, and I'm sure she had, more informed things to say about this than I will.
Everyone does. Mina from Medicare. We have the head of population health at Beth Israel as well, who has very strong views about Medicare Advantage versus Medicare Shared Savings Plans. Who's the former head of the ACO Foundation as well. Just interviewed John McDonough, one of the heads. I don't think he's the dean, but one of the heads of the Harvard Public Health School. He's disappointed. Yeah, he believes he was one of the architects. He's disappointed. Senator Burr, who's takes credit for diluting ACA. He was one of the chief senators who shot down as much of ACA as he possibly could. He's disappointed that any of it went through. So everyone has strong opinions on the subject. It is interesting to gather them now that we're 15 years later. And strange point of view that I have, I think we're still early to judge it because I still see so many private companies, whether it's managed care, accountable care organizations, ACOs, or whether it's primary care groups that are consolidators living within MA. I see so many of these operators working with government to still experiment. How do we make this better? And that still feels very early. I mean, we've just entered the age of AI and deep analytics, instantaneous, and so much of coordinated care is a function of how good is your analytics. So it still feels early to me.
I think that's generally true. Again, speaking from my experience as someone who travels around the country and visits primary care settings and big health centers and watching the way that, all of these actors have in fact tried to adjust to this new world. I think that's fair. I think that's fair to say. I'm a optimist by temperament, and I would say that looking at it, from a glass half full perspective, there is a lot of experimentation going on out there, and there are a lot of people trying to deploy this fantastic array of tools that I think people that are now available to do that kind of coordinated care and to do that kind of analytics that allow for people to, to deliver the best care in the right place in the right time, et cetera. And all of that is very hopeful. I'm also a journalist, so, cynicism sort of runs in the business. And I still remember right after, the President Obama signed the ACA in 2010, I remember going to Minneapolis and I was on a panel with a CEO of a big health system there in Minneapolis. And I was saying things like this, that, there was this exciting conversation about, accountable care and coordinated care. And he just shook his head and he said, it's all rhetoric. I'm telling you, things aren't going to change. It's going to be.
It's just words.
And, and I think as we have seen some of the consolidation go on and the way that big health systems particularly have used their market power, I'm not sure that some of that cynicism is misplaced.
Well, this is what's so disturbing about healthcare. It's too big. And so my wife always accuses me of rambling on. How can you not ramble on when it comes to any question or any answer regarding healthcare? So I can tell you that my space, the outpatient space, which has adopted more ACA structured incentive programs than any other space, right? Hospitals, health systems have pretty much turned their back on it. We're fine with fee for service. We're just going to continue to do things as they are, as they were, and drive 5 to 10% annual inflation rate on premiums. Payers happy to work with hospitals and basically pass the buck on to employers. Deal with it. In the meantime, the savings in healthcare have really come from the outpatient space, whether it's surgery centers or whether it's coordinated care or whether it's automation. The rapid adoption has come from the outpatient space. Not to say that they get a perfect bill of health when it comes to monopolistic behavior or, a little too excited about price increases. That happens too. But in aggregate, something has been driving down the cost curve in healthcare, keeping it at 17.4%. Something's working. And I would argue it's probably not been the hospitals, or at least up till now, the drug manufacturers. So there's been a lot of good, but it gets bundled into what's not working, with the monopolies that are still out there. So you can't help but expand into verbose descriptions of what healthcare is, because it's such a complicated space where so much good is happening, and yet there's plenty of stuff that, you wish it weren't so. You wish, hospitals didn't have local monopolies. God bless them. They do wonderful work, but there is a benefit to alternative options. You wish for transparency. You wish that payers didn't have so many state-based monopolies. They would also benefit from alternatives. You wish for better data, but it doesn't mean that there aren't a lot of positive trends out there. The healthcare that you and I grew up in 16 years ago, who knew a good doctor versus a bad doctor across the country? Did anyone know? Was there really national reporting at a micro level? You could zoom in on any doctor in any specialty. We have that today, and we have a whole list of metrics to define good versus bad. Doesn't mean it's perfect, but you can't compare today's industry to 16 years ago. We've come a long way.
I think that's right. Certainly visiting particularly advanced primary care shops around the country over the last 10 or 15 years, I can personally attest there's remarkable things going on out there. And, I wish my elderly mother could access one of those places.
We haven't quite fixed nursing homes yet.
We haven't fixed nursing homes. But the thing, I think you're right, some of the bad behavior overshadows that. I think the other thing that really overshadows it is that because of the way that healthcare is financed in the US, the experience that most patients have, whether they're going to outpatient or inpatient, it's more acute in the inpatient space, obviously, is the sort of out-of-pocket bills that they're getting because of the way health insurance has sort of evolved in the US.
Yeah.
And, that's obviously the space that I spent a lot of time the last few years exploring. But I mean, it's just devastating to people, and it colors everybody's views. So we can all be happy that yes, healthcare stayed at roughly 17%, and that's really good news, for a lot of different reasons. But it's so stressful for patients to deal with the out-of-pocket expenses that we saddle them with. And getting back to our earlier discussion about the ACA, it is one of the signal failures, I think, of the law, that its architects didn't sort of wrestle with that way that most people experience healthcare. And that is like as a bill that they get in the mail.
I want to come back to that. We're going to spend time on billing and premiums and deductibles, because I agree with you. I think and I smile a little bit because whatever experience I have from other countries and other citizens and how they feel about their healthcare, there's always something they point to that they hate the most. It just varies depending on which country. So in England, it's the waiting list.
100%.
Definitely not the cost. In France, it's the lack of coordination. I go to get treated in one location and then I need 3 other locations and none of them are speaking to each other. So I'm starting from scratch everywhere I go. There's just zero inter-institutional cross-sharing of information. And in some other country, and these are advanced OECD countries, right? In a place like Germany, it might be, or Japan, it might be excessive reliance on hospitals. Everything goes to the hospital. You have an issue, off you go to the hospital. Where is the outpatient? In Scandinavia, the doctors aren't excited enough. They're not paid well enough. Everyone's
a
got
universal
something.
law.
Everyone's got something. So
everybody has a complaint, no question.
We rarely complain about waiting lists. I think that is changing, but we didn't grow up in an industry where, you heard about 2-year waiting. But if there's something that everyone finds issue with, it's the economics. How could this possibly cost this much? Why does it cost less over there? Why do I not understand my bill? And so that reality has been there throughout. And so my question to you, we'll come back to billing in a second because it's such a rich topic. But just taking a step back, so Kaiser versus the LA Times versus other media institutions that I think you mentioned the Washington Journal. Where were you during 2008?
I was at the LA Times.
You at the LA?
Okay. But in our Washington bureau. I'm sorry.
Washington bureau.
I was working out of Washington. Yeah.
All right. So compared to me, forget ChatGPT because it will be a superficial answer. Let's get the real meat. Difference between the world and the mission of the LA Times versus the Kaiser Foundation.
So, the LA Times was, and to some extent still is, a traditional news organization, right? In the sense that, and when I started at the Washington Bureau of the Los Angeles Times in 2006, we had 50 plus people here in Washington for the LA Times. It was a massive organization. It distributed around the country. It was, we had 25 foreign bureaus. It was a very large, a smaller version of the New York Times, which, I'm sure everyone it has undergone incredible strains, as a lot of news organizations have, and it's much diminished. But its mission was, a traditional news organization. KFF Health News, which is, where I am now, which is a division of KFF, formerly known as Kaiser Family Foundation, has a very different mission in the sense that my day-to-day job as a journalist is similar for the most part. I'm going out, I'm writing about the big trends and what I see happening in healthcare in this country and to some extent overseas as well. But we distribute what we do for free to other news organizations. And with the idea being that because we're foundation funded, we have the luxury of distributing a product, and it's in the public interest to make available to general readers, no matter, whether they listen on NPR, whether they read in the New York Times, or whether they get, information from talk radio or cable TV, that there should be good, well-informed, balanced healthcare news out there. The other thing that's really exciting, I think, about our mission is that I get to actually work directly with local news outlets to help them produce their own coverage. And, I mentioned earlier, a lot of the work I've been doing the last few years is about medical debt and the strains that patients face. I've been helping news outlets in North Carolina, Connecticut, Texas, Minnesota cover this issue in their own backyards. And at a time when local news is under incredible amounts of pressure, we're losing local news outlets in America. I think there are really, really dangerous implications for democracy because of that. It feels like this is a sort of constructive place to be. Does that make sense?
It does. It does. So I want to dig into the Kaiser Foundation coverage of one or two topics, because there's nothing like asking the source. And I'm not sure that these are stories that you yourself generated or researched, but They were interesting to me. I mean, I'm guilty of the same crime that I think all humans are, which is I get a little bit of data and then I form an opinion. So the best way to mediate that or remedy that is to get the right information. For me, private equity in healthcare. It's a topic that Kaiser has covered. And when I get these little headlines across my screen, it's usually negative. It's usually inflationary. We see private equity driving up costs. It's normally, less focus on quality. It's gruntled clinicians, gruntled patients, profit, profit, profit. It's private equity. What more do you want from me, says Kaiser. Of course, private equity is entirely profit orientated. You can't find an animal out there that's more bottom line orientated than private equity. Surely in healthcare, let me give you the examples of them running amok. And I want to bundle into that AB 3129, which was the anti-private equity, but ended up being anti any kind of outside ownership of practices and hospitals in California that passed the House, passed the Senate, and was ultimately vetoed by Governor Newsom to the surprise of everyone. Sort of out of left field, just vetoed it. Am I right? Is Kaiser dead against private equity in healthcare? And the cynic in me says, well, of course they are. They run California Health, right? The health system runs
let me stop you there.
The name down with private equity because we want the market for ourselves. So correct my poor thinking.
Well, so you should know KFF, the Kaiser Family Foundation, has no connection to Kaiser Permanente.
I assumed you would say that. Yes.
Well, I mean, that's important.
No, you're independent. You're not influenced. So no doubt. But am I right in describing that it's mostly a negative view of the private equity? I don't remember seeing too many articles that read, hey, private equity in healthcare, fantastic. Here are the 10 things that they've done. We love them. More of this, please.
Well, no. So a couple of things. Number one, so I have not done a lot of that reporting on private equity's ownership of delivery. I've done some reporting on private equity's involvement in billing and patient financing. And I can certainly say that in that instance, what I saw wasn't particularly positive. But I think you're right in general terms that the media, and we are a member of the media, have looked skeptically at private equity. I wouldn't put it in quite as simplistic terms as you just did, that it's either everything is bad or we should be writing stories that are rah, 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 look at the great stuff that private equity is doing anywhere. I mean, that's not generally the way journalists sort of look at things either way. So yes, you are correct. We have done some critical coverage of private equity's work in healthcare, but I wouldn't, most of that is done by my colleagues and I don't frankly feel qualified talking.
Okay, so I gave you a Siskel and Ebert test. Now I'm going to give you more of maybe a Rorschach test. So, but with a skew. So if I gave you an image of private equity in healthcare with a direction to say, give me the positive impressions that come to mind. First impulse. What are 1, 2, 3, 4, 5 positives that you think private equity is probably driving into the industry that without them we would struggle?
Again, I'd rather talk about things that I've covered, Roy, just because otherwise it's just speculation. I don't know.
Okay, so maybe we dig into as it pertains to billing, and pricing and deductibles and all that stuff. Have you thought about how private equity, beyond the Team Health case study of surprise billing and Envision, right, beyond the anesthesia case study, but just the other 900 platforms that they own? That's 2, right? Blackstone owns Team Health still to this day. I don't think they've been able to offload it. I think Envision is Apollo. I'm trying to remember who owns Envision.
I think that's right. Yes.
Yeah. So beyond Blackstone and Apollo, and as I mentioned to outsiders looking into private equity is 350 different firms, right? Active in US healthcare investments. Each of them own 2 to 3 assets. That gets you to 900 healthcare services assets. I'm not talking about life sciences, and I'm certainly not talking about venture capital. So it's 350 actors. 2 of them get a lot of press. If I really wanted to broaden the circle, I would say 5 of them get it. I'd throw in Cerberus, I'd throw in Carlyle, and maybe Ares. And what's interesting is all of them have roots in Drexel Burnham and Michael Milken and 1985 junk bonds, which I would argue really isn't private equity at all. It's distressed leverage buyouts and loan to own, which is really how Apollo made their name. So if we're left with the other 345, it didn't come from Drexel and are simply guys with a lot of money or gals with a lot of money. It's a lot more mixed these days, thank God, who want to invest in businesses and see them grow. Not that different to venture capital. So when it comes to medical billing and claims and dealing with patients on that level, do you think that there have been any positives that have come out of that? Like investment in systems and technology would be an example of one.
I mean, there may be. It's just not, as I said, a space that I'm super familiar with. You know,
Okay.
I mentioned that one of the billing outfits that I have taken a look at, I guess that would be the sixth out of the 350 that you mentioned, was
Can you
involved.
name them or you'd rather not?
No, I can name them. So it's a company called Access One, and Access One is a North Carolina-based company that has private equity involved. I can't remember which firms actually were investors, but they are essentially a patient financing firm that goes to health systems and offers to service the patient billing through payment plans. And in our experience researching them, the model appeared to sort of move a lot of patients from no interest financing payment plans into interest payment plans. And that was a departure from the traditional practice in hospitals where if a patient would go on a payment plan that was typically not with interest. And in many cases, in what we found out, patients didn't sort of seem to understand this system. And it was frankly not entirely clear in the way that these products were marketed that patients knew what they were getting into. So, you know, is private equity to blame there? I don't know about that. I know this is a company that is taking advantage of a weakness, I would say, in our system, that patients are left with these enormous bills they can't afford, and they're making money in that space. And that's neither here nor there, but it is clearly adding to patients' distress. That I can say, you know, I think a lot of patients who had that experience weren't terribly thrilled with it. I can't tell you that that necessarily besmirches the 350 private equity firms that you're talking about. But there's one example in patient financing that, frankly, I didn't think was so positive.
So it's interesting. I'm looking at Frontier, which I think is the name of the private equity group that invested in this asset. And I'm just trying to understand what makes them tick, because usually these funds are quite transparent on their website. One of the things that they offer is, what do they own? It's always suspect to me when a private equity group doesn't actually share its portfolio on its website, which is the case here with Frontier, frontiercap.com. So I don't know them. And
that's correct, Frontier, yeah.
Yeah, and a few thoughts in response. My experience, we've worked with 120 different private equity firms. It's actually not our main focus as a business. And we've been critical of them publicly, as I am on this podcast with a lot of listeners, directly. And we were most critical actually of them in 2022, when we thought most of them who were buying assets shouldn't be, because they don't know the space. And I don't think I know the space. I've only been in it 15, 16 years. I don't think that's enough. It's a very complicated space, delivering care, working with clinicians. And so 350 buying is too big a number. And they were chasing a bull market where it was just too easy to invest and exit, which is what they love most. And you find all kinds of actors when there are that many actors. And some, you look at and you think, you're not really approaching this market the right way. It's a patient market. It's a discipline market. You don't want to overpay for anything. You want to leave room for mistakes, leave room for all the wild machinations of healthcare. You want to prioritize the right things, taking care of doctors. That's really what everyone here is supposed to be doing who isn't a doctor, right? Otherwise, get out the room. And so they're going to be examples of investors who prioritize the wrong things. And I think one of the regs that I've been a fan of is more transparency about who owns what, which I think 13 different states have acted upon, and I applaud them all. It really scared me when I looked at the MedPAC report that the federal committee issued or sponsored between 2018 and 2022. They waited 3-4 years for this report to the Commerce Committee, I think it was. I can't remember which committee sponsored it, but it was a big deal. They waited many years for it. And then you looked at the report and there was something like 6 investments that were studied, mostly nursing homes, 1 hospital. And I'm sitting there going, where are the other 900 healthcare companies that private equity has acquired during this time frame? They're just not in the report. And it turns out that the actual reporting, the transparency of who owns what, has been a stumbling block for a lot of regulators across the country. So more knowledge is a good thing. And the question of raising rates, interest rates on patient balances and patients being surprised, caught unawares, I could certainly imagine that happening. I've been in the business. I've had a billing company in healthcare for 15 years, one form or another. I've had to deal with patient balances. I've had to deal with patients. And by the way, patient balances, whether they're deductibles or co-payments, is always a difficult thing in healthcare. You have regulatory obligations in terms of transparency and notice, managing expectations. You have absolute confusion over the balances, because still to this day, no one can tell you what something's going to cost to the penny before they actually deliver the care. And once they deliver the care, everything needs to be evaluated. You send in claims, you send in notes, and the payer lets you know whether they agree with you or not. So the whole thing is somewhat up in the air. It doesn't mean that you can't offer a lot of notice and education, but it is a little bit complicated, the whole process of who owes who what in healthcare with all the different billing codes that are out there, right? And then the ongoing care that follows, right? We talk about coordinated care. So these things are not easy. Look, I will say this, not just this one example, but my view of patient balances across the industry is that it's become of ever greater focus to actually collect that dollar amount over the last 10 years. Why? A, the government has focused on out-of-network and the out-of-network game and writing off patient balances and really focusing on exorbitant prices charged to insurance companies and the government, but less so the government. And this idea that you don't have to worry about patient balances, therefore you can keep doing that. One of the ways to counterbalance that is to say, no, whatever you charge a payer, if a patient has their respective percentage obligation, you have to demonstrate that you're really going after the patient for that balance too. So the whole going after thing became very much heightened by the government in terms of regulation and policy, and everyone reacted, okay, I do have to take patient balances very seriously. 2, we've been in a deflationary environment for healthcare in many aspects of healthcare over the last 10 to 15 years relative deflation, relative to other parts of the economy. So if outpatient care is growing at 0.5% per year and cost of wages, labor is growing at 3 to 5 and during COVID, 10% a year, you really can't afford to ignore patient balances. And anytime you look at a patient balance and it's 90 days old, 180 days old, you have to ask yourself, A, shouldn't you be charging interest because de facto it's acting like a loan? And B, don't you want to be charging interest because without interest, what incentive does the patient have to actually take the balance seriously? Like as you would charge any aged AR, accounts receivable. So I sort of, to some extent, I don't know the details of Frontier and this asset. And, I think of American Express charging 28% interest annualized on aged balances, day one, past 30. That seems usury to me. So if someone is charging 28%, I don't know that I can justify it. But some interest versus zero interest, it doesn't sound that unreasonable.
I mean, I guess it depends on where you sit and how you view sort of the relationship between the medical provider and the patient, right? I mean, if it is a transaction like buying a car or buying a television or putting something on your Amex, sure. If we think about it as a different kind of transaction, and I would argue that those who work in healthcare, when they look in the mirror, they tell themselves that we are engaged in something of nobler calling, then I would argue we should have a different conversation about that. But even putting aside the sort of values discussion about whether or not the sort of provision of healthcare and the financial arrangements around it are somehow different than, how we buy other conveniences in our economy. The fact of the matter is people can't afford these bills. So, if you are getting a $5,000 bill, because chances are you're going to have trouble paying that, whether or not there's interest associated with it or not, and whether or not the provider is under a contractual obligation to try to collect that money because of the contract with the insurance or because Medicare is requiring copays and so forth to be collected. The fact is people don't have the money to pay it. And, we can argue that, okay, well, people shouldn't be buying the big screen TVs or they shouldn't be getting the personal watercraft or whatever it is that we think in this country, to quote the president, they should only have.
There are a lot of TVs
out 30, right?
Sure.
The fact is people can't pay these bills. And that is resulting in a whole constellation of problems for patients and, in my experience, challenges for providers. And that's why, this patient financing company and others are in that space. But it is now like a defining feature of our healthcare system, and one that I don't think we sort of reckoned with. And because we haven't really reckoned with it directly, all of these kind of ad hoc things happen, right? There's out-of-network billing games. There's revenue cycle management companies that are selling various ways to optimize collections. There are debt collection attorneys that specialize in suing patients who haven't paid their bills. There are public relations firms that specialize in defending hospitals against the bad press they get when people like I ask questions like, why are you suing that poor person that, can't afford to pay $10,000 when they're living in an apartment that costs $1,000 a month. And so all of that together is to say that the conversation I think we should be having is not whether or not 28% or 10% is usurious or not. It is, what is the public policy that we need to start talking about? Because the system of billing that exists right now, it doesn't work for patients. It doesn't, as you probably know better than I, doesn't work terribly well for a lot of providers either. And, it's imposing almost indescribable suffering on people. I mean, I hope we don't leave this discussion without focusing on kind of the lived experience of patients who have to navigate this. I appreciate that it's difficult for investors and challenging for outpatient providers, but all of them adapt. If you are getting a lien put on your home, or you're having your wages from Walmart garnished, or you have to empty your savings, or you're getting dragged to court because you can't pay the anesthesiologist or the outpatient surgery center, no matter how great they may be in restraining overall healthcare costs. That's, I would argue, a fundamental failure of the system. And it also betrays a lot of the rhetoric that we hear from providers who I believe are interested in providing the best service and the best healthcare to the patients that come through their doors. But if the system is impoverishing those people and pushing them to levels of stress that, are literally killing people, I think there's a problem. And I would argue it's possibly the most pressing problem that we have in our healthcare system today.
Yeah, I think it's another example of our industry being such a pain in the butt because every question is a riddle wrapped in an enigma on top of a paradox.
Let me stop you there, because I actually think it's more than a riddle.
Yeah.
I mean, people, I can't tell you the number of people that I have visited around this country, like sitting in people's kitchens, on their front porches, in their backyards, and listening to them describe how their lives have been upended because they got, a $5,000 or $10,000 or $15,000 bill. Like, that's not just a riddle.
Well, let me explain. I'm going to be stubborn with you and still call it a riddle.
Okay.
I meant something by it.
Yeah.
So give me a chance. Give the other side a chance. You're going to find that you agree with the other side. So because the other side agrees with you. There's no way you looking at ChatGPT. There's no way that you look at $220 billion of outstanding patient responsibility, medical debts. And I'm sure if I did a trend, I don't think it's 220 billion 10 years ago or 20 years ago, right? That's a growing number. It almost feels analogous to student debt that, I don't know, 20 years ago, half the size it is today. And the problem just gets worse and worse and worse. I think the latest is 1.7, 1.8 trillion. So one of the issues we have with what we're dealing with with medical debt is that I think this problem is getting worse, not better. There's no way that you look at the number of legal actions. The estimation is several thousand health system to patient lawsuits per state per year. Hospitals suing individual patients. Most of these patients, are living paycheck to paycheck. And here comes a large system. And now you have to go to court. Now you have to find a lawyer to deal with a meaningful claim, right? And I've seen that with my own eyes too, right? anecdotally. I've been witness to a hospital going after someone. It is very scary, right? So when I say it's a riddle, it's because at a minimum, there's a massive block called patient balance problem, which is in that riddle. It belongs there and it's not going away and no one should ignore it. We haven't solved it. Why it's a riddle and not just a problem that everyone should just try to fix tomorrow is because everything in healthcare is a riddle. Everything in healthcare is codependent, confusing from an economic standpoint, delicate, which doesn't mean that we get the luxury of just ignoring it by saying it's complicated. I wish it was that easy. We just ignore these problems. These problems are fundamental problems in human decency, quality of life. What does it mean to be in this country? But here are some other problems for you that are in this soup bowl. Utilization of healthcare, right? We complain about patient balances in the same sentence that we complain about cost of care in America. Same sentence. And those two sentences are actually diametrically opposed because you can't have 350 million people trained to not care about their responsibility, their balance, their financial consequence of using those resources and still expect healthcare in America to become less expensive over time. Those patients, and they have been, the system, the government, our government has been pushing more patient responsibility, larger co-payments, larger deductibles through a payer community that has facilitated that into the system from 2% patient responsibility 20, 30, 40 years ago to 4% to 6% to now 15%. By the way, not so much in hospitals. So this is another part of the riddle. A lot of hospital lawsuits for very large bills, because hospitals tend to charge a lot more, right? Hundreds of thousands of dollars versus tens of thousands versus thousands versus hundreds of dollars. Not so many outpatient lawsuits, right? And so also the rate of inflation, gap between patient responsibility, the level of education. I'm about to get a $500,000 procedure, right? I'm about to go through $2 million worth of care for my cancer treatment, right? I'm about to get a heart transplant. These are massive bills. And so how do you balance educating the patient about, when it comes to heart transplant, there's no education required, right? It's acute and it's very necessary. But the amount of hospital visits that are excess, that didn't need to happen, the amount of medication that didn't require, the amount of consultations that didn't need to happen, the amount of taking advantage of the system because someone else will pay for it. The government will pay for it, the employer will pay for it, the union will pay for it. So that's why I call it, it's not as straightforward as, obviously, patients shouldn't ever feel responsible for a meaningful amount of money. And what happens when they are responsible and they're not in a position to pay? How do you deal with that? There are ways to deal with it, but I don't know that we've perfected it. I wouldn't say we've perfected it at all. To give it to the courts and say, go sue, doesn't sound great.
So I have to jump off here in just a couple minutes. But before we go, I guess I would say this, to having sort of watched the evolution of the healthcare system over the last 15, 20 years. You are right that we have sort of moved as a country to shifting greater and greater responsibility onto patients. There's a lot of reasons for that. But I would say that the evidence now is pretty clear that that experiment has been a complete failure. And the idea that making patients have, quote, skin in the game, as some economists called it back in the day, to sell this idea, which was premised on this notion that there was a problem of overutilization in the US healthcare system, which I think has been shown to be actually not so much the case, that system just, it doesn't work. People can't shop around for a heart transplant. They can't shop around for a multi-year course of chemotherapy to deal with one cancer.
Well, they shop around for in-network insurance. They shop around for closed networks.
But not in a way that I would argue, not in a particularly informed way. And in fact, we've sort of seen all the problems that people have trying to even compare networks. So I think, maybe we leave it with this, but I think, we started this conversation by talking about the Affordable Care Act, what it achieved, what it didn't achieve, how many stars it gets in the movie review. And we talked about the importance that extending coverage was. The unfinished business is really, thinking about how to have financial protections, from my perspective, for patients. And in order to extend those financial protections to patients so that insurance really will prevent people from financial ruin, there's a whole lot of other stuff that has to happen, to your point about riddles, right?
I'm not a fan of financial ruin. It doesn't feel appropriate to ruin someone financially over treatment. I would certainly agree with that.
And so, I think looking forward, as we think about sort of, I'm here in Washington, and think about kind of what is the sort of national agenda in healthcare going forward, assuming we kind of get over all the drama we're living with right now. I think it is thinking about how can we move this system to a place where people have financial security when they get medical care, and what are all of the things on
can it be progressive?
Can it be progressive? Does it mean we have to think about regulating prices in some way? Does it mean we have to think more about the role of health systems versus outpatient versus independent? There are a whole
and patients paying $50 copays is reasonable.
Maybe it's patients paying $50 copay, but it's not patients paying $5,000
or $100,000 on a $50,000 income. Doesn't quite work.
So I have to run, unfortunately, but I really appreciate you having me on, Roy.
I thought it was very rich in discussion. I feel that way because I could use a nap now.
Okay.
So I loved it. I hope you enjoyed it too.
Thanks. Send me a link when it's done.
I will, and I'm looking forward to seeing you in person at one of our events as well.
That would be fun. All right, take care. Bye.
Thanks, Noam. Bye.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.